So my name is John Waterbor. I'm forgotten but not gone. I came to UAB in 1981. That's how many years ago? 3 or 4? 44 years ago, for a year or two, to maybe 3, to earn my DrPH degree. I had already gone to, as the academic journey thing. I attended Drexel University in Philadelphia, my hometown. As an undergraduate, was a biology major. Then I was admitted to the University of Pennsylvania School of Medicine, a prestigious place, which I didn't like very much, as it turned out. I got an MD there, decided practicing medicine was not what I wanted to do. So while I was at Penn, we from Penn call it Penn. While I was at Penn, I got a Master of Science in Epidemiology. They had a new growing epibiostat master's program. Then, thinking I want to get a doctoral degree in something like that, I rushed around to find where it was kind of late in the academic year was about to start. It was like July, August. Like, where could I go quickly get admitted for fall semester starting? And I was admitted to, as a quickie thing, there are connections from Penn, University of Pittsburgh, one other that I forget where, and UAB. When I came to UAB, I thought, this is an odd place. It was in an old building, Tidwell Hall, but the people were very nice. And I met Dr. Cole, who became my mentor in cancer epidemiology, and Dr. Lehman and a few others. Later, I met Dr. Lewis, but that was kind of later. I won't say they begged me to come, but they said, we need faculty. You can be a doctoral student and a faculty member at the same time. Because back then there was kind of like no rules. So I said, okay, I'll stay a year or two. I'll earn my DrPH, doctorate in public health, and then probably go back to Pennsylvania. So that was, by the time I earned that was 1987. And I forgot to go back. So I'm still here. So I teach 2 courses this semester, Principles of Epidemiologic Research, Epi 610 in class. I don't like online. I'll give online lectures in other people's courses, but I don't like to teach online courses. And I'm teaching cancer epidemiology and control. Cancer, my main hat. My second hat is injury. So today, without further ado, we'll talk about epidemiology and control of injuries, dedicated to Dr. Fine. Now, Dr. Fine he's still alive. Quite a character. He's long retired, several years. A synopsis of Dr. Fine's academic and otherwise career is a little bit, not time for that now, but Dr. Fine approached me. We got to know each other at some guest lecture, and we decided we needed to teach an injury course, and we did that together with a number of guest lecturers. Dr. Fine retired. I retired, and I'm still here. He retired, and he's at home. But anyway, dedicated to Dr. Fine because he taught me most of what I know. Read the outline later. A big thing in epidemiology is case definition. What do you mean by injury? Everybody in the room, I think, has been injured at one point or another. How do you define injury? Well, the definition we use is transfer of energy, kinetic, thermal, heat, chemical, electrical, nuclear, or removal of oxygen or heat beyond the human body's tolerance, resulting in impairment of body structure or function. I'm not going to read all my slides to you, but some of them I will. The other ones you can kind of glance at. How do you measure injury in a population? Well, the usual measures in epidemiology we talk about are incidence, prevalence, and mortality. Incidence is an event. You were an incident case when you get injured, and you were forevermore either a prevalent case, or if you're cured, then you don't have injury anymore. But incidence is kind of at a given time and place. Prevalence is ongoing until you're cured or free of injury. And mortality, of course, is death. Surveillance. So one of my instructors back then, and then I helped him teach his course, Dr. Mike Metz taught infectious disease epi, and he was big on surveillance. And there's the definition of that. So if you have a disease or injury of interest to you or to your boss, wherever you're working, and you'd like to collect in ongoing fashion how many cases of this disease or injury are happening per day, per week, per month, per year, and beyond that, what about them? So when you have injury surveillance data, the fundamentals of infectious disease epi again, person, place, and time. who got hurt in terms, not their name necessarily, but maybe demographic description. Where did it happen? When did it happen? The nature of the injury. You can read the other things you'd want to record, circumstances, intentionality. That's a big thing in injury epidemiology and control, and other data. And these slides are available to you forevermore. So here's a little bit of a diagram. And what it says is, if you want to do injury epi research, depends on what injury. I mean, you're talking about sports injuries, or are you talking about intentional injuries? Where are you going to get the data? This is kind of hard to read because it's not linear, it's kind of circular, but these are different locations where you might find injury data. So we talk in injury epi about unintentional injuries and intentional injuries. You called unintentional injuries accidents, so you will be $1. This is a Dr. Frying thing. When you use the term accident, to some people, maybe we don't think a lot about it. Like I had a car accident. In the injury epidemiology field, we don't like that because it conveys to the listener, it was a bad luck. Gee, I was, it just happened. We say that an unintentional injury epi, many or most are predictable and preventable. That is, if you have a car crash, maybe you were a distracted driver, maybe you had little kids in the back seat screaming, maybe you were fiddling with the stereo, maybe you were looking out the window, maybe the brakes failed. These are all risk factors or contributing causes to unintentional injuries. Intentional injuries, that's kind of an emotional thing to study, but I think it needs to be studied. Any actions, stabbings, gunshot wounds, fistfights, with the intention or goal of inflicting injury on someone else. Okay. These are some terms. We classify injuries in a number of ways when we're doing either teaching or doing research. Overuse injuries versus traumatic injuries. So overuse is what it sounds like. So if in your job or your vocation, like you were a baseball pitcher, or you're someone who works in construction and you're digging things a lot, if you have excessive and ongoing stresses in one part of your body or another, you can get an actual injury. So there's a biological, physical problem, maybe a muscle problem, ligaments, whatever it might be. The pitcher's having UCL damage. As an aside, if I have another, if there's another hole in the schedule for Epi seminar, I have already prepared, for whoever wants to listen, sports injury epidemiology, which is a big thing now. And if you get into that area, you can make money. UCL is the ulnar collateral ligament, and that's the ligament that is often overstressed and puts baseball pitchers on the so-called disabled list, which is now called the injured list. I'm a Phillies fan because I'm from Philly, but a lot of Braves fans, Atlanta Braves, their starting rotation of 5 pitchers in the beginning of the season, who are going to every 5 days, and that's the starting rotation, and there's relief pitchers. Of the 5 starters on day 1, 4 of them had to sign off for the year because they had ulnar collateral ligament damage, and they had to have surgery, which is called Tommy John surgery, named after the first pitcher that had that problem. That's a commercial for next time. Traumatic injuries, that's a different category. Again, these are just terms. Traumatic injuries, or bingo, either a fist, a motor vehicle crash, MVC is the usual abbreviation, some sports. So there are some contact sports that kind of the goal of it is like beat the other person senseless. But anyway, that would be if you're actually injured, and I would think you would be, that's called a traumatic injury. Another term, if you get into injury epi, catastrophic injuries. Catastrophic from the word catastrophe, like a major bad thing happens. Okay, so catastrophic injuries, the way that previous injury epidemiologists defined it, maybe there are more than 3, but 3. Spinal cord injury, traumatic brain injury, 3rd-degree burns. And by catastrophic, we mean they may well be fatal sooner or later. And if they're not fatal, it's pretty much the effects are with you lifetime. So if you have spinal cord injury, you may have paralysis, other problems for the rest of your life, whether you die sooner or later. Traumatic brain injury in the news all the time. I just saw a paper, I didn't read it yet, about, again, people who had a traumatic brain injury in sports, recovered, but later, now we test down the road, can you still do math calculations and stuff 10 years later? And there's still some lingering problems, so it gets into brain injuries. Third-degree burns, very deep burns, where you're not the same after this happens. Again, can be unintentional or intentional, that's injury epi cut a different way. And there's examples of the unintentional, don't call it accidental, and intentional. Okay, deaths from injury in the US. See, I think injury epi, I think, should be a required course in our School of Public Health. Unintentional injury ranks number 3 overall as a cause of death in the US. And it's the leading cause of death, bullet number 2, unintentional injury, call them accidents if you must. The leading cause of death, ages 1 through 44 in the United States. So that includes, it excludes newborns in the first year of life, ages 1 through 44, which is a kind of half the human life expectancy. Last I looked at life expectancy in the US, and that calculation is kind of complicated. Women or females about 82, males about 78. So ages 1 through 44 is kind of like the first half of your life. You can, if your age is 1 through 44, you can call yourself young. The leading cause of death in that age category is unintentional injury. What kind of unintentional injuries kill you? Well, skipping to the last bullet, there's fires and burns, there's drowning, there's suffocation, there's electrocution. But the main two are, which you might guess, but I didn't give you a chance to guess, motor vehicle crashes. The other main unintentional injury that you can die from is poisoning. Now you may think, why is that classified as injury? I didn't do the classification, but that's the way it is. And that's, I guess, the idea is injuring your digestive system or your biology inside. The poisoning is occasionally from someone who may be the little child that drinks mommy or daddy's cleanser, or drinks something poison unintentionally. But the main unintentional injury is drug abuse. So drug abuse and motor vehicle crashes, number 1 and number 2 is categories within unintentional injury deaths. Intentional injury, there are 2 intentional injury deaths, 2 ways you can die. That you decide to take your own life, called suicide. That ranks number 10, cause of death overall. And homicide, you die at the hands of another, as they say. Homicide, well, back to suicide. I don't know a lot about suicide epidemiology, but I know the phrase, in case you go on to something in injury. Commit suicide is kind of like not the way to put it. This is one of those things where if you say commit, people in suicidology are concerned that it transmits the message that it's a crime, and they don't like to say it that way. So taking one's own life is maybe the better way. Death at the hands of another. Most homicides are intentional and punishable by law. However, homicide, killing at the hand, or dying at the death at the hands of another, if you kill somebody who's invading your home, then, and you can prove that's what was happening, that person's going to kill you or your significant other or your child, and you kill them first. So this is an aside. Homicide may not be a crime, and it may be, it depends on what happens. Okay. So ages 1 through 44, suicide and homicide, again, number 10 and number 12 overall, but if you collapse to the ages 1 through 44, they rank higher. We'll see that in a minute. Whiskers. This is an interesting database. They make, we like to make a word out of anything we are looking at. Web-based injury statistics query and reporting system. Database lists injury mortality rates by age, type of injury, It's called Whiskers. And what you can do then, it's a major, lot A lot of data there. If you ever want to do any injury research, especially mortality, that's a gold mine there. In the top 5 causes of death, ages 1 through 44 are, in fact, unintentional injuries, suicide, and homicide. Now we will see if this works. Leading cause of death in the US for ages 1 through 44, 1981 to 2023. Here's the deal. Do I have my laser pointer? I'll just fall. In the upper left-hand corner, it says play. I'm going to click on that in a minute. And it says 1981. When I click on it, it's going to scroll forward to 1982, 1983, 1984, all the way up to year 2023. What will happen as you go year to year to year, you will see the bars elongate, or what's the opposite? Get shorter. So right now it says in 1981, total death counts per year, unintentional injury, 58.5K, 58,500, malignant neoplasms, cancer, 22,000, homicide, number 3, where my cursor is, 17.9, heart disease, 16.4, 15.9, suicide. So in 1981, that's how we lined up in deaths, ages 1 through 44, 1981. Now, when I click, again, you can watch the years go by in 1981, 2, 3, and you can watch the stripes get longer or shorter, if this works. If it doesn't work, it's your fault. Go. 1982, 1985, 1988, and some of the stripes may be changing how high or low they are on the list. 1996, year 2000, 2005, 2010, 2015, now watch. 2017, 2018, 2020, 2023, that's the last year, okay? So in 2023, presuming the data are correct, which is epidemiologist, if you were going to use it, you'd have to see how this was done. I'm going to accept it the way it is. Unintentional injury deaths, 2023, 83,300, ranking number 1. Again, this is ages 1 through 44, so with the young people, as compared to 45 and up to 120, however long you're going to live. Suicide, second on the list of causes of death, ages 1 through 44 in the US. Homicide, number 4. Malignant neoplasms, cancer sneaks in there, number 3. Heart disease, pretty much, causes 3, 4, 5, or on the same same ballpark. Cancer, homicide, heart disease, and then others there. Injury control. So in epidemiology in general, my way, again, different epidemiologists term things differently. I teach epidemiology, this is one thing, and control is another thing. Epidemiology is causes. Control is, now that we know what the causes are to some extent, what do we do about it? So control, I think of as interventions, like stop people from smoking, have them wear body armor if they're going to get hurt, whatever it might be. So interventions for injury prevention, reduce severity. Okay, etiology, that means causation. How does injury occur? So as in epimethods, we talk about a causal web, that it's not straightforward, or maybe it may seem so in the beginning, but there are often 2 or 3 or more risk factors, contributing causes that work together. Like, again, maybe you can be drunk and drive a car a lot of times and nothing happens, but when you're drunk and driving a car and it starts to rain hard, then there's a problem because you're not quick enough on your reflexes, that sort of thing, okay? Multifactorial causation. Back in just epimethods, multifactorial means what I just said. One, I guess a gunshot to the brain from there, maybe that's multi or unifactorial, you're going to die. But for the most part, injuries and diseases, heart disease, cancer, stroke, there's got to be a recipe, a conundrum. Things have to come together in a bad way to produce a case of that disease or injury. So each ingredient, I think of it as a recipe. sometimes when I teach epi methods, I would say, if you want to get cancer, which I hope you don't want to, tell me what you would have to do. If you smoke a lot, will you get cancer? Maybe your chances are higher, but that's no guarantee. A lot of people smoke a lot and get other diseases, or, so you have to look at the causal web, or how contributing causes may fit together, and they make up a sufficient cause. So when you study epidemiology of cancer, heart disease, stroke, injury, you want to figure out what are the contributory factors, you might say. Okay. So here's my example again: the drunk driving. If you want to kill yourself in a car, I hope you don't, and you drink a lot, you're increasing your chances, but it's no guarantee. So that is a contributing cause. It's not sufficient. So contributing causes, again, we'll use the drunk driving as alcohol example. So when do the contributing causes play a role? Well, these 3 bullet points are called, and we're leading up to the Haddon matrix, the pre-event, event, and post-event factors. So pre-event, drunk, bullet number 1, drunk man gets behind the wheel. So that's something that, we have this on film or something. We knew that happened, and that was before the crash, okay? That's a pre-event factor. Contributing causes at the time of the event. Speeding. So he or she, I'll just use a he, was driving 90 miles an hour after getting behind the wheel when he was drunk. So there's a risk factor right there. Do we know if anything's going to happen? Well, we don't know yet. We didn't watch the rest of the movie, but that would be an event factor. Then the other, or the third wheel there, is post-event. Post-event means, okay, in this example, the crash occurred. Did anyone die? Is anyone or everyone okay? What goes on? Post-event. Post-event means, in essence, recovery, death, disability, whatever it might be. Besides knowing risk factors being something that affects your probability of getting a disease or injury, okay? Each contributing cause that I just mentioned, pre-event, event, post-event, can then be further classified as whether it is a host factor. We sometimes talk about this in, again, infectious disease epi. I think our roots of injury epi, I think, are in infectious disease terms. Host factors, agent factors, vehicle, and environment. Now, an agent. In chronic disease epi, we don't usually talk about agents. In injury epi, an agent is a necessary cause. Necessary, that is, for a particular injury. In chronic disease epi, we don't usually talk about necessarily like one thing only is going to make you sick. Maybe there are some examples. So besides, again, pre-event, event, post-event, we want to look at which of those factors are host factors, person injured, the agent, what kind of energy. Remember, injury from energy, kinetic energy, thermal energy, lack of heat or lack of oxygen. Then the modifiers are physical environment and social environment. So the Haddon matrix is what's coming up. Who is Dr. Haddon? American physician, public health advocate, one of the few in the 1970s, and there's still not many infectious disease epi people as maybe there could or should be. He was one of those people that like to be a trailblazer, and he wrote a famous paper within injury epi circles and created a matrix. I'm not sure if he named it after himself or somebody else named it after him, called the Haddon matrix, a grid of risk factors based on, again, the second bullet, the triad, agent, host, environment. That's what we teach in infectious disease epi, pre-event, event, and post-event. Voila, there is the Haddon matrix. So what this is all about is when you have a case of injury, like we are the law enforcement or emergency medical services on the team came, and there's been a crash and this person is dying or maybe has died, whatever. Of course, the emergency medical needs come first. But if you want to diagram out why did this happen, then you would want to, in kind of an ongoing injury, maybe not a formal study, but just to understand better how could similar cases of this injury be prevented. So you'd have to look at what happened, and it would help if you have witnesses or, in a sense, a movie of everything ongoing that mattered, and fill in boxes that boxes 1 through 12. Some of them maybe don't get filled in with data that you think had a determined in part whether the injury would occur. So, sorry. Columns 1 and 2, host factors. So age, weight, etc. So in a motor vehicle crash, for example, elderly have higher case fatality. Case fatality means the proportion of people who die from the disease or injury over a given period of time, okay? Agent, type of energy or absence of air and heat. In a motor vehicle crash, it's kinetic energy, okay? Now the vehicle, this is one of those terms where the word vehicle is used in a couple of ways. Vehicle sometimes means a motor vehicle, like a car or a truck. Vehicle, in the more general sense, vehicle means the means of getting something from here to there. So the vehicle here, in this example, the vehicle is a vehicle. The vehicle is a car, truck, or a motorcycle, okay? Now, columns 3 and 4 of the Haddon matrix, and then we'll fill one in. Physical environment and sociocultural environment. Physical environment, my example is median barrier on a highway, preventing crossover head-on crashes. So, you know, some highways, if you're going real fast and driving like crazy, you might get over to the other side. It's designed to prevent head-on crashes. Everybody you crash into is going to be going the same way you are. Sociocultural environment, a little subtle, and when we teach injury epi, you have to figure out if I had my car crash and I was drunk driving, is my wife responsible in some way because she told me not to drink that day? That sort of thing. So there are things that we try to fill in everything we can think of in the Haddon matrix, and later we may say, you know, what are we going to work on here? Is the responsibility for being injured kind of self-inflicted injury? Is that anybody else's fault? You could say yes, or you could say no. You could say, well, the family or significant other, whatever, okay? Socioculture. And then I use the example of the distracted driver. I think we all now and then, I don't do it to excess. I don't know if I've ever used my cell phone, balanced my checkbook, and ate lunch while driving. That would be overload for me. Okay. Row 1 to 3, pre-event, event, post-event. Okay, here is physical, social environment. Okay, host factors. In this example, frail man, diminished mental status, slowly walks down a road to the drugstore. Agent, necessary cause of an injury, necessary cause. Coming down the road is a speeding, weaving truck carrying a lot of kinetic energy. Okay. Physical environment, getting dark outside, roads narrow, there's no streetlights, no sidewalks. Social environment, like you might, once you know about this man, like why is he there to begin with? Social environment, man's family was too busy to drive him to the drugstore, told him to walk. So this is a situation where, putting the pieces together, you could say maybe an injury's, you know, if you knew this all in advance, this conditions are right for a bad outcome here, okay? Okay, so when you, after an injury occurs, you draw a Haddon matrix, if you're kind of in the, after medical help is given, of course. Assess the context or setting in which the injury occurred, organize your thoughts like what happened. That is, if you had a movie or you were a witness to the whole thing, kind of slow that down. Like what happened first, what happened second, what could have been done differently for a better outcome, pathway to injury, and of course, mostly you're looking for modifiable or controllable factors. So things like everything was going well, and there were no predictions of a tornado, but I was driving and a tornado hit me and killed me. I mean, there might be some things that you want to know for the Haddon matrix, but they may not be modifiable or predictable. Okay, here's another example. Regarding death of a child by smoke inhalation in a house fire, what is the agent? The agent is always a type of energy or lack of oxygen or lack of heat. When we had plenty of heat here, we had lack of oxygen. The vehicle for suffocation is smoke. It filled the lungs instead of oxygen getting in. The event is the lungs filling with smoke. And okay. Now the Haddon matrix captures experience of an individual. So it's Jane Smith or John Evans. We have that, and maybe we want to look at that because maybe it's a typical type of injury. Primary, secondary, or tertiary prevention is then what we want to effect, what we want to do. Primary, secondary, tertiary, 3 layers. What we want to do is modify the host, the agent and vehicle, or the environment, or maybe all. So as you know, the goal of public health is prevention. Primary prevention, reduce the probability or risk of injury, and that's the ideal. So I think primary prevention, whether you're in public health with an interest in injury or heart disease or stroke or any other kind of disease or outcome, primary prevention is certainly what we want to achieve if we can. In the example of injury, keep the uninjured people uninjured. Secondary prevention means, at least in the injury definition, reduce severity or reduce the outcome in terms of severe injuries. Tertiary, reduce the probability of severe injury or death. So when we look at that, again, in certain situations, because for some injuries, primary prevention may be easily possible. For others, maybe the best we're going to be able to do is secondary or tertiary. Okay, control measures, passive or active. So that's a term we use to say, okay, for this man with the, we'll go back to the car crash example. When we started, the United States of America or the world started building cars with airbags in them. Airbags, I guess there are some cars where you can turn them on and turn them off. I don't know if they have that anymore, but I use that as the passive intervention. Passive means you, the owner of the new car, you don't have to turn on your airbag anytime you go out and drive. It's there. Okay, so that's passive, which is ideal. Now it can come into controversy if something is built with passive features, and some people say, I don't want an airbag. I mean, what am I going to do? How am I going to? Anyway, we'll leave that for philosophical discussion. Active interventions are something like a seatbelt. Now, I think there used to be cars where the seatbelt, you sat in the car and then the seatbelt, and then some people didn't like that, or maybe they got trapped. So seatbelt is an active intervention. You got to buckle it. If you don't buckle it, it doesn't do any good sitting there. Okay. So Dr. Haddon then decided one way to get people thinking about countermeasures, control measures for injury is to come up with a kind of a plan that he called the Haddon's countermeasures. And there are 9 of them. Maybe there's 10. Okay. So my example here in the white font is examples for reducing burns from various sources. So Haddon countermeasure number 1, prevent the creation of the hazard in the first place. Example, don't smoke in bed. Haddon countermeasure number 2, reduce the amount of hazard brought into being. So this is a different example, but they all deal with burns. People sometimes in the garage are storing lots of flammable stuff. Maybe don't store quite so much. Number 3, prevent the release of the hazard that already exists. So be careful how you deal with anything that could catch on fire. Make sure there are safeguards there. Countermeasure number 4, modify the rate or spatial distribution of release of the hazard from its source. So I don't have a little baby at home, but use low flow warm water faucet for baby's bath. So that would be something, because that maybe new mothers or new fathers give baby a bath and they turn on the hot water and they don't realize it's 200 degrees immediately. No. So this could be a modify the rate of spatial distribution or release. Example, separate in time and space the hazard and that which is to be protected. So another example, in injury epi, we sometimes do case studies where there's a little story and then students have to fill out a Haddon matrix. Mommy and daddy are in the kitchen cooking Thanksgiving dinner and there are other relatives around and things are boiling. And there's things in the oven and it's very hot and it's very confusing. And little kids, toddlers, who want to go anywhere because they like to toddle, they're going out into the kitchen. No, separate in time and space. Material border. I lived in my youth, I lived in an apartment complex, and my next door neighbor apartment had a big fire. But luckily for me, I mean, he wasn't there, so he wasn't hurt. There was a firewall built, and it's not in every apartment house, where if this apartment catches on fire, I don't know what the wall is made of, but it's sturdy. The fire has a really hard time going that way. So that's to protect the hazard, and which is to be protected by a material, meaning a tangible, something you can hold, order. Okay. Countermeasure number 7, modify relevant basic qualities of the hazard. The iron that you use if you have an ironing board, where the heat goes off if you don't move it much instead of just staying on forever. Measure or make what is to be protected more resistant to damage. Example there is suntan or sunburn. And people do this all the time, at least up north where I was from. They're so hungry for a suntan that when it, because it's been cold winter and it's snowing and raining, and then there's a span of 2 or 3 really hot sunny days, and they just like lay out as many hours as they can. Could be skin damage there. Begin to counter the damage already done. Medical or other attention by professionals trained to do whatever is needed to be done. Countermeasure number 10, stabilize, rehabilitate, and repair the object. Severe burns, okay. Choosing feasible countermeasures. What's feasible and what is not depends on the situation. Look at time, effort, cost, human behavior. My example there, well, we don't have any motor vehicle crashes if we don't have any motor vehicles. So no more driving, no more cars, walk, find some other way to get there. Okay, probably not feasible. One of the people I look to for advice is Yankees catcher Yogi Berra, who is known somewhat for his good baseball playing, but also he had a number of sayings that stay with us. He once time said, in theory, there's no difference between theory and practice. In practice, there is. So like things that look good on paper don't always translate to actual.
As good as it isn't over till it's over.
It ain't over till it's over. He already said that, and that's indeed true. Okay. Implement countermeasures. Once you have decided, and we're almost done, and then I'll take questions. Implement countermeasures by means of the 4 E's. Okay. So you have your injury scenario. Jane Doe gets injured in a certain way, and you have the Haddon matrix filled out as best you can. That didn't help Jane Doe so far. Now, what do you do, or someone who's in authority, what do they do? Interventions are in injury epi said to be there may be more than this, 4 general approaches. Education, there are 4 E's, so you can remember what they are on some kind of test. Education, environmental modification, enactment, enforcement, engineering. So education is, of course, we're in a university of higher learning, and education is certainly key. Not everyone who lives in the Birmingham area knows what students, active students, are learning. So education, however that's done, that gets into primarily in my thinking, things our Department of Health Behavior does. So education to prevent disease or injury or to reduce severity, education about anything in public health. Again, the health behavior folks are more expert than I am. There is counseling, like one-on-one. There are now media education, kind of broadly speaking, and there are other means. Environmental modification, well, again, make things safer out there. So do put in the median strip down the middle of the highway. Environmental modification is maybe making the speed limit lower in the example of car crashes. Enactment, enforcement, whatever is already there, is it being enforced? So that, I'll use the speeding example. The sign on the interstate may say speed limit 65, but if you sit there with your radar gun and watch, everybody's going 75 or 85. So if you think excessive speed is a risk factor for car crashes, I think it is in general, or maybe on a certain road or certain situation, then enactment or enforcement is maybe what you want to do. Engineering, redesigning the physical environment, engineering and then making big changes could be time consuming and costly, but sometimes that's what needs to be done. Choose countermeasures that are evidence-based or data-based. Maximize chance that they will work. Has the countermeasure you're considering been used somewhere else? Haddon matrix, again, gives you 12 opportunities or places where you could, on the surface, make a change. Consider all 12 boxes, choose the best. And again, you, as the epidemiologist, you may not be in charge of doing any of these things. It's more that if you worked with emergency medical systems, physicians, law enforcement, whatever you think, back to the environmental modification, enactment, engineering. Education, again, is key. At what level? I mean, I'm not an education expert. Do you want to start doing Haddon matrices with little kids? Maybe. We'll see. Okay. Now for today, thank you for your attention. So with the help of our Student Affairs Office, we have double listed injury epidemiology and control, which I haven't taught with or without Dr. Fine for, I think it's 3 or 4 years. The way our curriculum works, at least in the MPH program, maybe there's not a lot of interest in injury, and or there's not a lot of flexibility to take electives because you're kind of lockstep in if you want to graduate in a reasonable time. Anyway, we're going to offer it both for master students. You would sign up if you're interested or talk to me first, Epi 603. And we are double listing it then for undergrads. My thinking was, it was my bright idea, but Dr. Padilla in our department liked it. Undergraduate students, maybe some of you are undergrads, or maybe just any students. Wouldn't you be interested in a course that talks about things like prevention, early detection, access to care for things like motor vehicle crashes, drug abuse, suicide, homicide? Now, I know that and my main area is cancer, but with all due respect to cancer people, stroke people, cardiovascular people, Ginny Howard's not here today. Those are all very important diseases to prevent, and prevention, I think, has to start earlier. Things like diet, nutrition, not smoking, and all that. On the other hand, I hope none of you die anytime soon, but I just went through 44. If we're playing roulette and probabilities, the biggest chance, the most likely, is unintentional injuries of one sort or another. So I think that's something that at least should be offered as an elective every year, every other year. Dr. Shrestha, again, I told him if he has I have this prepared for some other purpose, but I can buff it up if there's another opportunity on his monthly epi lecture schedule, prevention control of sports injuries, and that's big business. If you're an epidemiologist, you have anything of an interest in injury, and if you like sports. So the professional leagues, the National Football League, the Major League Baseball League, the hockey leagues, the other leagues, they need to keep their star players. You're a star player. We need to keep you on the field. Because if we pay you a lot of money, which we do, and then you're hurt all year, this is a double whammy. Like, this is bad. So injury epidemiology, I have a good friend, Glenn Fleissig, American Sports Medicine Institute, and he is on the payroll, partly, with Major League Baseball, and he studies sports injuries and who gets those elbow injuries, the ulnar collateral ligament that require surgery, and that gets into, and he's attuned to prevention. Dr. Frank Jobe was the first surgeon that did that surgery, and now lots of surgeons do. And surgeons are getting, I mean, it's a talent. They're getting rich, and maybe they should, because they're doing, then the pitcher takes off like a year and then can pitch pretty well again. But of course, the ideal is prevention. And for prevention, we need studies on risk factors. Maybe I'm a pitcher that pitched just as much as you did. You needed UCL surgery. I didn't. Like, what's the difference? And we threw about the same number of miles an hour. So that's an epidemiologic question. Figure out, again, in epi, often you're looking at the people that got the disease or injury versus similar people demographically that did not get the injury or disease. How are they different in some key way or ways? Okay, there's some references.